malformations, basilar artery occlusion, intracranial ICA stenosis. They also use transcranial Doppler to assess patients who they suspect are brain dead. And also this is used to monitor sickle cell patients. Some exclusive applications of transcranial Doppler are microemboli detection during carotid endarterectomy, detection of PFOs, and to monitor blood flow during surgery. Okay, so let's talk about cerebral aneurysms first. So a cerebral aneurysm is the bulging and weakening of blood vessels in the brain. Rupture can be deadly. Mortality rate is about 50%. So the rupture can cause the blood flow to flood the brain tissue, and this is going to result in a subarachnoid hemorrhage. I think we've already covered that briefly. So that's where the blood kind of cuts through the meninges, and so it like goes in between two layers, and it causes a lot of problems. The main thing that it can cause is a vasospasm. And so that's when one of those arteries constricts and it causes distal reduction in blood flow. So patients who do develop vasospasm have poorer outcomes than those who don't. So the vasospasm kind of leads to delayed cerebral ischemia. So basically, it's like stroke-like symptoms on top of the hemorrhagic stroke that they've already experienced. Usually the spasm is delayed, and it happens about on day 3 after the subarachnoid hemorrhage. It peaks on days 6 and 8 and can last for about 2 to 3 weeks. So this is where transcranial Doppler comes in. So they want to do serial monitoring to kind of detect when it happens, how bad the vasospasm is, and if the treatment is working. So the kind of treatment that they can give them is vasodilators like papaverine. So basically they insert it via catheter directly into the vessel, just proximal to where the spasm is located.
TCD, TCI more effective than CT, or is it kind of just using a combination?
So it allows for like real-time monitoring. So that's what's good about it, so that they can see like what the immediate effects are of the treatment.
Versus transporting patients.
Yeah, yeah, and it's portable, so it's easier to use. Some of the symptoms of a ruptured cerebral aneurysm, really intense headache, the worst headache of your life, diplopia, double vision, nausea, vomiting, stiff neck, sensitivity to light, seizures, loss of consciousness, cardiac arrest, death. How many of you have watched Game of Thrones? Nobody? You? Okay. All right. So did you guys know that Emilia Clarke actually had 2 ruptured aneurysms, and she had suffered subarachnoid hemorrhage? So she almost died twice. And so it's really rare that this even happens in a person this young. She was like in her 20s. No, she was like in her 20s while she was filming Game of Thrones. It happened twice. So for her, they treated her with endovascular coiling. So basically they kind of deploy a coil into the artery to kind of like block off blood flow. And then it happened again 2 years later to her. So this is kind of like a real life example of subarachnoid hemorrhage and ruptured aneurysms, which is really rare. And it's really rare that it happened twice on the same patient. So she's really lucky that she survived. Okay, so there's different types of cerebral aneurysms. The first one is saccular, which is also known as a berry aneurysm, and it's round. It's filled with blood. It forms on arteries at the base of the brain usually. And this is the most common type of intracranial aneurysm. So a fusiform aneurysm is bulging on all sides of the artery, whereas the saccular is just kind of like on one side of the artery. There's also mycotic aneurysms. That type of aneurysm is caused by infections, which damages the walls of the artery and can cause it to bulge. So those are the three types, but the most common type is the saccular. Okay. So let's talk about cerebral vasospasm. So the spasm usually happens after the subarachnoid hemorrhage, and it's a major cause of mortality in those patients that do experience the vasospasms. Blood flow changes will appear the same as a stenosis, so it's going to be like a high velocity. So you want to do a baseline study on day 0 and repeat the study on day 4 of the vasospasm. So you'll be able to see evidence of the vasospasm within 3 to 4 days after a bleed, if it will happen. Day-to-day changes of greater than 20 centimeters per second will usually progress to a severe vasospasm. The bigger the bleed, the bigger the risk of developing a vasospasm. And they can range from mild to severe. Mild usually is asymptomatic. Severe really decreases that distal perfusion. So it causes a lot of deficits that include confusion, stroke, death, loss of consciousness, and giddiness in the patient. Okay. So for a transcranial Doppler exam, what you want to do is locate the MCA. So you're going to use that transtemporal window. Look for velocity increases and record the highest mean velocity. A diagnosis of vasospasm is based on the high mean velocity. So you want to make sure to record the sample volume depth for subsequent studies, because you want a Doppler at the same depths on following studies. Note the direction of the anterior cerebral and the posterior cerebral. You can run into some issues when you're scanning, because usually there's some sort of brain swelling, and that's going to displace like the anatomy to different depths than what you're used to. So like say the MCA is at a certain depth, it may be displaced deeper because of all of the brain swelling. Sometimes there's metal clips that are used to clamp off the aneurysm. That can block the signal. You may have an uncooperative patient, which is likely with some sort of trauma like this. And also, you may or may not be able to penetrate the skull just based on how thick the skull is. Okay, so here's some of the mean velocities. Normal is going to be around 30 to 80. Mild vasospasm, you're going to see anywhere from 120 to 140. Moderate, 140 to 200. Severe is greater than 200 centimeters per second. And some labs use an MCA to ICA ratio. Greater than 6 usually means that it's a severe vasospasm. So that MCA to ICA ratio helps to differentiate between high velocities that may indicate vasospasm, or like conditions like hyperdynamic flow caused by different things like low hematocrit, increased blood pressure, that type of thing. So the ratio is really useful in helping to differentiate. So basically you divide the time average mean velocity of the MCA divided by the ipsilateral distal extracranial ICA, which is the part that we measure when we're doing a carotid Doppler, but you're using the transcranial. A normal ratio is less than 3. Mild to moderate vasospasm is greater than or equal to 3. And like I said, severe is greater than or equal to 6. Less than 3. So this is kind of a sample chart that they use to track vasospasm velocities throughout time. And we're going to see that in this case study that we're about to go through. Okay, so this patient, SG, she's 46 years old, female. She suffered a subarachnoid hemorrhage of her left MCA on 6/26. The aneurysm was clipped that day. On the 7th day post-op, she developed a mild to moderate vasospasm of the left MCA that they detected with transcranial. The increased velocities went away after a few days, but on 7/10, about 14 days post-operatively, she had a vasospasm in the right MCA, and that one turned into a severe vasospasm. She declined pretty rapidly. They did an angiogram that confirmed the vasospasm. And so she underwent 3 local papaverine injections to the right MCA. So once they injected that, the velocity started to decrease. But there was also a progressive but kind of transient spasm in the left MCA at the same time during the 3rd week post-op. But she didn't have any symptoms from that episode, so they kind of just left that alone. And so here's that chart that they used to track everything. So they did 3 injections here, here, and here on 7/10, 7/11, and 7/12. So the exam on 7/13 showed that the velocities were decreased to the normal range. And there was also a spike in the left MCA velocity on 7/19 to the severe range, but then it just came back down. And since she wasn't experiencing any neurologic symptoms, they kind of just left it alone, and it resolved on its own. So this is showing you the peak of that vasospasm, the injections, and after like the 2nd and then definitely the 3rd, the velocity started to come down significantly. And she started improving. So here's an angiogram that they did. The right side was the side that she had that severe spasm on, and you can see the MCA, the flow is really, really reduced through here. And the left side on the same day was normal. And so with transcranial Doppler, there were really, really elevated velocities and like really high flow going through that right MCA, and the left MCA was normal. And so this is just showing you, the angiogram in relation to that chart that we just went through, where you can see the spike and then it coming down after those injections. So there's a graph on the bottom here. 7, 10, 11, and 12. 10, 11, and 12. What's that? There?
Yeah. To the left of the arrow is that large.
I think that's an aneurysm. Yeah. So they didn't explicitly say it, but I'm guessing that's what that is.
So is it more common that your vasospasms are going to happen proximal to the aneurysm?
That I don't know whether it's more, I would think that it would be more common for the spasm to be distal.
Yes.
Because I thought that the aneurysm on the left.
She had, okay, so she had spasms on both sides. but the right was more severe than the left.
And
They clipped the left MCA, but she also experienced a spasm on the right.
um,
Now, why it happened on both sides, I don't know. I don't know what triggered that, but I mean. Does that answer your question? Kind of.
Yeah. So,
Yeah. I don't know. They didn't make that really clear in the book. So, this is the information that I have is what they gave me. So they didn't really say why she had a spasm on both sides, but probably because there was all that blood and pressure in her brain and just kind of triggered both sides to spasm, I would guess. But that's just a guess. Anyway, she was discharged. She made a full recovery and didn't have any symptoms at her follow-up 1 month later. So treatment worked for her.
Didn't flip the right side.
They clipped the right side.
So they clipped the left side.
Wait, let's see. Let's go back. Yeah, they clipped the left side.
So you have the vasospasm, the large aneurysm.
So she had an aneurysm on the left side. They clipped the left MCA, and then she had spasms on both sides. But the side that they clipped didn't give her like that much neurologic deficits as on the right side. Okay, so transcranial Doppler is also used for emboli detection. So surgical procedures like cardiac surgery, carotid endarterectomy, angioplasty, and stenting can kind of introduce air emboli and particulate matter, especially like a carotid endarterectomy where they're like scraping away that plaque. Some of it can travel. So what they do is they'll do like simultaneous monitoring, like bilaterally, with the transcranial Doppler to kind of pick that up. So the Doppler picks up high intensity transient signals or HITS, which are also called microembolic signals or MES. The air emboli have kind of like a chirping sound, and it has a longer signal duration than particulate matter. Usually they have higher intensity reflected signal on the spectral display than a particulate emboli. So that's for the air emboli. Air emboli seem to have fewer neurologic consequences than particulate emboli. So that particulate matter is made up of platelets, atheromatous material, or a combination of both. So the ability to differentiate between air and particulate emboli isn't really that great yet, or wasn't that great when the book was published. I don't know the state of it now, but most embolic events have a mixture of all of those. So air and particulate matter. So does it really make a difference to differentiate between the two? Probably not. So for emboli detection, during intraoperative monitoring, they use a low frequency transducer. Transcranial color imaging is used for diagnostic purposes, not for monitoring. So that's why they use transcranial Doppler. So they either do it unilaterally or bilaterally with the headgear. The 2 megahertz transducers are put into the lateral probe holders, and they're adjusted to receive the signal from the MCAs through the temporal window. So transcranial surveillance for microemboli and CO2 reactivity typically is performed with the bilateral transducers because it can monitor both hemispheres simultaneously. And it records long periods of spectral Doppler information. For emboli monitoring in carotid endarterectomy, you can use one transducer, but it has to be attached some kind of way, so they use the headgear. It's not currently available for transcranial color imaging, so that's why they use the Doppler, the non-imaging transducer. And they'll monitor for at least 20 minutes, and it has an automatic emboli counter. So it'll count the number of emboli. Yeah, I don't know how it works, but kind of cool. Okay, so some transcranial Doppler systems use multiple sample gates, and they simultaneously record signals from different depths along the MCA, and these are called multi-gated units. So multi-gated units might be better at differentiating between true emboli from artifact. So an embolic signal is gonna be recorded sequentially between the sample volumes as it travels along the MCA. But an artifact is gonna show up simultaneously at all the sample volumes at the same time. So new transcranial Doppler technology uses color M mode simultaneously with the multi-gated spectral Doppler to kind of help distinguish artifact from emboli. So another method to differentiate emboli from artifact is to record and display the audio spectrum of the event. Emboli and artifact have different audio signatures. So this is an example of an embolic signal. This spike here, it's kind of like a burst. So the spectral Doppler is going to show a spike, which you can kind of see here. And it's going to correlate to the audio spectrum, which is also going to show a spike at the same time. So an artifact will not be a burst like this or like this. Okay, so figure A shows a microemboli within the spectral Doppler and at the audio spectrum on the bottom. So it's at the same time, and they're both really sharp bursts. Figure B is showing you artifact in the spectral display, and a diffuse audio spectrum that's not characteristic of an embolic signal. So here's the audio spectrum is kind of like diffuse, kind of wavy, but it's not like a distinct spike like this embolic signal here. And so figure C is showing you a burst or a shower of microemboli. So it's like a lot of microemboli. So it kind of overloads the Doppler signal processing because it's so intense. And so the spikes appear throughout the vertical dimension of the signal display. So it goes from top to bottom. So this is a shower of microemboli. Okay, so there's certain criteria for identifying a microembolic signal. The signal has to last less than 300 milliseconds. The amplitude is at least 3 decibels higher than that of the background blood flow. And that is for older systems. For newer systems, the amplitude doesn't really matter that much. So this criteria kind of really isn't relevant anymore, but I just put it there just to kind of show you guys. The signal should be unidirectional unless it's a shower of microemboli. You'll hear like a snap or a chirp on the audio output. The signal should appear in all unilateral Doppler sample volumes as it travels along the vessel. Okay, so now we're going to talk about detection of PFO with the transcranial Doppler. So you guys know what a PFO is, obviously. Usually the PFO leads to a right to left shunt. So a lot of times if a PFO is present, a venous thromboembolism can develop and go from, it'll be shunted from the venous side to the arterial side, and it can cause a stroke and other symptoms on the arterial side. About half of all young stroke patients have a PFO. In patients with cryptogenic stroke, more than 3/4 have a PFO. And in patients who haven't experienced any of those symptoms, the prevalence of a PFO is like 10 to 30%. So cryptogenic stroke is a stroke where they don't know where it came from. So what they think is that it's caused by emboli that originate in the venous circulation and pass to the arterial circulation through a PFO. Paradoxical brain emboli just means that a thrombus from the venous circulation crossed an intracardiac defect into the arterial circulation. So they use this term to kind of identify things that they can't identify. It's also referred to as a venous to arterial emboli. So cryptogenic stroke basically comes from the venous side, crosses a PFO to the arterial side. Okay, so the way that they test for a PFO, basically they're going to put an IV in a patient. They have the bilateral headgear. They record the MCA signals, and then they'll do like a bubble study, agitate saline, push it in through the IV. Patient will do a Valsalva maneuver. If there's no shunt, the bubbles go to the lungs and dissipate. If there is a shunt, the bubbles will go to the MCA, and you'll see that microbubble shower. Bubbles will cause hits, high intensity signals in the MCA. It's kind of delayed after a few seconds. Only if the PFO is open, though, you'll see those bubbles. And so this is a normal transcranial Doppler bubble test, and you don't see any kind of like signal here, no showers or anything like that. This is a positive bubble test, and you can see the microbubble showers showing up on the spectral display at all of these sample gates. Oops. Okay. So this is basically just showing you again, the microbubbles showing up as a shower in the spectral display. Okay, so transcranial Doppler is also used in the detection of AV malformations. So in AV malformations, the arteries have an increased systolic and diastolic flow velocities, and they have very low pulsatility indices. So basically, it means a low pulsatility means that there's not much difference between the systolic flow velocity and the diastolic flow velocity. It's kind of the same. High pulsatility would be the opposite. It would be like increased resistance. So like a high resistance waveform. Transcranial Doppler is used in sickle cell disease monitoring. These patients have the propensity to develop intracranial stenosis, which increases their stroke risk. So transcranial Doppler evaluates the velocities in the ICA and the MCA. If the mean velocities in the MCA are greater than 200, that is significant. And as far as what we're concerned with, sickle cell kind of goes deeper than what we're going to cover. So main thing is that if the velocities are over 200, then that's significant for sickle cell disease. Okay, so transcranial Doppler also helps in determining brain death. Increased resistance in a typically low resistance vessel is highly, highly suspicious. There's 4 stages of brain death. So A up here is showing you the typical flow pattern. It's a low resistance flow pattern. That's normal. That's normal flow. Stage 1 in brain death is going to be increased resistance with the end diastolic flow kind of reaching the 0 baseline. Stage 2 is kind of an oscillating flow pattern. You're going to have flow above and below the baseline, but they're equal, so there's no net forward flow in that situation. You're going to have retrograde diastolic flow, so it's going to be oscillating above and below the baseline. Stage 3 is where you have these short systolic spikes and basically no diastolic flow. And the last stage of brain death is no flow detected. So it's just going to have no signal. Yeah.
So I guess I've seen such a different.
Yeah.
I was going to say, possibly give the this.
Oh, the thing at the top about the meeting.
So A is normal, B is stage 2, and C is stage 3.
Yes. There's no graphic for stage 1 or stage 4. Any other questions? Okay. All right, so we're gonna do, oops, what did I just do? Real quick, we're gonna go over there was no graphic that I could show you for stage 1 and 4. Okay. So we're gonna talk about upper extremity arterial anatomy. Arms are really fun to scan. It also can be kind of tedious because those arteries are really small. But yeah, she's still there. Oh, right.
The same probe.
Yeah, same probe, same probe. So some indications for why a physician would order an upper extremity arterial exam is if they hear some sort of bruit, if the patient is experiencing like weakness in the hand or arm, or any kind of syndrome like thoracic outlet syndrome, which we won't talk about today, but we will in another lecture. Decreased arm blood pressures, any abnormal vertebral waveforms or like retrograde flow. There are contraindications though, however, you should not take arm pressures in an arm where a patient has hemodialysis access ports, because that's just gonna cause a lot of complications. Okay, so here is a reminder of where the subclavians come off the aortic arch, the innominate, vertebral and all that. Okay, so the subclavian artery, the right one comes off at the innominate, where it branches into the subclavian and the common carotid. The left subclavian is the third branch off the arch, which you guys know already. So the subclavian is going to run laterally and down the border of the first rib. It becomes the axillary artery at the first rib. It gives off some branches. The most important one, which you guys know, are the vertebrals. It also gives off the thyrocervical, the internal thoracic, and the costocervical arteries. But the most important branch is the vertebral. Okay, so the axillary artery is a continuation of the subclavian. It starts from the outer border of the first rib to the axilla. What's the axilla? Does anyone know? Yes, the armpit. So the axillary gives off 7 branches, which you don't have to know. And then it becomes the brachial artery. So it ends when it becomes the brachial artery at the outer border of the teres major muscle, which, as far as I can tell, is right around this area. So that's where it becomes the brachial. Around this muscle. The brachial artery extends from the margin of the teres major muscle. It goes down the upper arm and ends about 1 centimeter distal to the antecubital fossa. So it's going to bifurcate past the bend of the elbow. And it bifurcates into the radial and the ulnar arteries. So the radial starts at the distal brachial where it bifurcates. It's going to travel on the lateral side of the forearm, which is the thumb side. It gives off a branch to form the superficial palmar arch. And it ends in the deep palmar arch by joining with the deep branch of the ulnar artery. And the ulnar artery is also part of the bifurcation of the brachial. And it travels on the pinky side of the arm, which is the medial side. It also gives off a deep palmar branch, and then it terminates in the superficial palmar arch. The ulnar artery is the major source of blood flow to the hand. And that's going to be important later on. The interosseous artery comes off the ulnar, and it runs between the radial and the ulnar artery. It's going to split into 2 terminal branches, which are the anterior and the posterior interosseous arteries. Okay, so the hand, which we don't really scan, but it's kind of important to know what's going on there. The superficial palmar arch is a terminal part of the ulnar artery and a branch of the distal radial artery.